Live. We should feel alive, and we should be able to connect with each other. By connecting with each other is the only thing that we can feel alive. And when we talk about connections, in the body, every organ is connected to another organ. Not just functionally, also structurally. Of course, through the fascia and the modifications of the fascia, the peritoneal fascia or the pleura or the pericardium or even the meninges. These modifications protect the structures and also maintain the position of those structures. Thickening of these fascias which are covering particular structures are called as the ligaments. I came here just to make you understand the distal perspective, or because for visceral course, Viscerosomatic manual therapy, all the registered participants received the pre-course materials, both the PDF and the preparatory videos. Of course, the visceral was covered as part of the previous courses. So, because we are always following, it's not just the topic which we teach how to handle patients. So one topic might include 3 to 4 other techniques which can be used in combination. It's very important in a patient-centered approach where we combine the techniques. So here I am here just to illustrate on this visceral model that how close are these nerves in the thigh, especially the femoral nerve, and of course the muscles which are here, right from the psoas major and the psoas minor and the iliacus, to also the lateral part which is the obturator foramen, that is obturator internus, obturator externus, and also you see the adductors which are on the what is called as the pubis bone. And after that, more posteriorly, you can see that here these muscles of the hip, and also like from the sacrum, the things which are coming to the femur, the muscles. And also posteriorly, you can see here that it is about muscles like piriformis. Okay, all that from the sacrum to posteriorly it goes. And of course here the bottom here is the pelvic floor. When you are looking at the connecting part, the male reproductive system, here also we can see these muscles arranged in different layers. Of course here superiorly we have the rectus abdominis. Okay, so that is from the pubis symphysis and going up toward the xiphoid process. So, and you have the pelvic floor, okay, the puborectalis, okay, for the rectum, and you also have here. So what is important here to see that all these muscles are interconnected through the fascia, through the intramuscular septum, and also they are, for example, an anterior group of muscle like obturator internus and the externus and the adductors connected to the pelvic floor muscles which are inferiorly there. Okay. So we are actually seeing this as a male reproductive system which is having the penis, the testis, the scrotum, and of course the lymph nodes. The posterior part, the larger part which is superiorly there, is the bladder, and you have the what is called as the entry points for the ureter, and then is the prostate gland which is here both the sides, and you also see that super or subcutaneous fat, the superficial fat which is there everywhere in between, acting as the cushion between the organs. So what are we actually want to explore here? When you open this and you see the actual sagittal section, where you see that from the bladder we have the urethra, and we also have the what is called as the prostate gland, and you have the rectum for the gastrointestinal tract. And of course here you can see that displacement of any structure, either the bladder is displaced anteriorly or posteriorly, will impact the other structures easily. But when you are talking about visceral to visceral, there is a lot of cushion that is provided by the fat which is present. But if the visceral structure is getting impacting on the bone or on the muscles, which are the somatic structures here, then only the impact comes to the somatic dysfunctions. So the patients might have a pubis symphysis dysfunction together with a bladder dysfunction or prostate dysfunction. So that is something which is totally related here. And also the rectum together with the coccydynia, the coccyx which is posteriorly there. So it's very, very important to understand this role. And you also have that commonly patients with sexual dysfunctions or erectile dysfunctions in men, especially because this is male reproductive system, they all have adductors being either in spasm when they are having pain during intercourse, or it can be what is called as the imbalance of the adductors right and left when they have problems like urinating towards one side. Okay, the penis may be deviated to the one side, which is actually not pathological, but if it is accompanied with urinary tract infections, if it is accompanied with the prostate enlargement, okay, or it is accompanied with what is called as any kind of premature ejaculation, okay, so sexual or urinary, definitely you can think of these mechanical evaluations. So when you are examining adductor length, so definitely it can influence the adjacent reproductive system, the structures, and you also see that psoas major, minor, and also the pelvic floor muscles together, and ensure that comprehensively the patient should be treated. So not only for the visceral disorder like sexual dysfunctions or urinary dysfunctions, but even for the somatic dysfunctions like an adductor trigger point, groin strain. Why groin strain comes only one side? So that means there is a imbalance between right and left. We as physical therapists, we think that dominant side, non-dominant side, so that is the asymmetry, so it is causing the somatic to somatic. Because of our lifestyle habits, it is affecting the adductors and developing the trigger point. But we forget to see that and ask the patient that, are you having any kind of irregularities or notable abnormalities with urinary or genital or even the rectal function? Okay, so patients may have sometimes even a simple thing of piles. Okay, so in the rectum, you might think that how it is going to do, what it is going to do with the groin strain. But when you are evaluating the patient, and a patient with the groin strain having a tender point in the adductors, okay, which we commonly find, which may be as a spasm also. But when I am doing a rectal examination, okay, so through the rectum, so with the gloved finger, I am examining the rectum for its mechanical properties, and I am maintaining this, okay, I am finding a restriction in the rectum, and I am maintaining my hand placement in that area. I have not removed my finger, and at the same time, if I am palpating the adductors or checking for how easy that muscle is, whether spasm is aggravating or spasm is reducing, you know the picture now, that the connection between visceral and somatic established. So that will pave the way for viscerosomatic manual therapy. Don't think that it is just visceral osteopathy. No, it is not visceral manipulation. Beyond that. So viscerosomatic manual therapy will include visceral facial releases, and of course incorporating the breathing, retraining and evaluation in every system and every organ, primarily for visceral dysfunctions and also for the related somatic dysfunctions. So it's pleasure on behalf of the Academy of Orthopedic Manual Physical Therapists as the course instructor to invite all of you and register for this course. This is especially very, very important as we are seeing first wave, second wave and third wave. If you see that first wave was more of theoretical webinars, Second wave was more practical demonstration, more clinical and certification courses, which happened in the AOMPT. The third wave is an upgradation and specialist in terms of untouched areas of the body like visceral system, splanchnology, and also the lymphatic course which is coming up. So please don't miss this course. Join the Vsmt course beginning in just a few days from now. Don't miss to enroll yourself. Okay, so good luck to you all. See you.